everybody. I'm going to go ahead and turn it over to Karen Wendell, and we'll get started since it's 7:30 Mountain Time on my clock.
All right, thank you, Victoria. Welcome, everyone. In response to the evolving COVID pandemic, we have launched this bi-weekly virtual learning community for the Mountain States to address COVID-19 management issues for our region. We welcome you to session 4 today and invite you to forward the registration link to other colleagues you think would be interested in attending. Today, our speakers will be covering post-COVID syndrome. As always, our topics will change every session, so please come for continued learning opportunities. You are welcome to suggest future topics, comments, and opportunities to better serve this group by way of the evaluation or sending Victoria or Caroline an email or a message in the chat box even today. We strongly encourage you to enter questions about the presentation into the chat box for us to address during the Q&A session at the end of the presentation. Sometimes if we don't get to all the questions, we might be able to get you those answers after the session. So please do enter those questions in the chat box as they come to you. Before we get started, we wanted to acknowledge this is a joint collaboration between the National Emerging Special Pathogens Training and Education Center, NETEC, Denver Health, and the Denver Prevention Training Center, the Robert Wood Johnson Foundation, and Project ECHO. My name is Karen Wendell. I'm an infectious disease doctor at Denver Public Health. Today's agenda is busy. We have a quick announcement from Carolyn Kroll, a tech check with Victoria, and then we'll begin our post-COVID syndrome presentation, followed by a case presentation and ending with your questions and answers. Carolyn?
Awesome. Hey, everyone. Following the great questions from our session from October 27th, we wanted to share a free resource available through the National Emerging Special Pathogens Training and Education Center, also known as NETEC. NETEC's mission is to increase the capability of the United States public health and healthcare systems to safely and effectively manage individuals with suspected and confirmed special pathogens. They have a website. I'm going to share my screen right now. Let's see. Let me navigate. Oh, here we go. Victoria is going to pull it up for us. On their website, it's a very user-friendly website. They have a bunch of free resources that they've developed and collated, including trainings, PPE information, standard operating procedures. You can see Victoria's pulled up a bunch of the information available. You can explore NETEC. They have a bunch of resources developed and collated. You can discover some safety preparedness resources. You can develop a plan for your facility. They have some templates available, and then they also have some resources available to implement some facility plans. One of the resources we did want to share that is more personal to your organization is the technical assistance request. Victoria, if you scroll up to the top of the website and go to back to the home page, if you click the NETEC button, supports, if you go to resources, technical assistance, support services, technical assistance, and scroll down, you can see this resource available. It says technical assistance is a consultation for a targeted and focused area that requires assistance. In the past, I have used their TAs to ask for support for programmatic help. And when I've requested that support, they've offered resources and responded to me within less than a week. And I've scheduled time with them within, I believe, 2 weeks to address my challenge and receive support. If you do want to request a technical assistance, you just scroll to that last question at the very bottom and click there. And then you can see how to input your information. So for the purpose of this demonstration, we want to request a technical assistance. You add your email address, what you want support with, and then a brief description. And then you can also add attachments and submit that request. We wanted to share this resource with you in case you were interested in reaching out to NETEC. NETEC is a great resource available any time to request support for special pathogens. Thanks, Karen.
Okay, and I think, Victoria, are you doing a quick tech check for us?
Yes. So just wanted to again do a quick tech check. If everyone in the chat can put in where they're from, since we do have, a couple new speakers they're not familiar with where everybody's from, and it's always nice for them to see. So I put in there, I'm from Inglewood, so go ahead and put where you're calling in from. So that's where you can also place your chat questions if you come up with any for our presenters today. You can change your view so that you can see the speaker view, which would make one person large. That's up in the top right corner. You can start your video if you don't have it on. So for all of you who are not on camera yet, we would love to see you. So go ahead and hit start video down in your lower left corner. Next to that is going to be mute or unmute, depending if you're muted or not. Again, go ahead and click unmute if you want to verbally ask your question or add any comments to our discussion today. But please reach out if you have any questions. You're welcome to chat me. And with that, I'll turn it back to Karen to introduce our first speaker.
All right. Well, we are very fortunate today to have Dr. Jana Jokela. She is currently the acting regional dean at the University of Illinois College of Medicine at Urbana-Champaign. She'll be covering post-COVID syndrome. Thank you so much for joining us, Dr. Jokela, and I'll turn it over to you.
All right, wonderful. Thank you so much. And it's really delightful to be here this morning. I'd like to thank Dr. Frank for extending the invitation originally, and it's just terrific to be there. Let's see, I believe I can share my screen, so I'll go ahead and do that. Okay, and now we'll get ready here. And okay, there we go. Can everyone see my screen okay?
Yes.
Okay, great. And I trust you can hear me okay as well.
Yes, we can.
Okay, wonderful. Thank you. Well, again, it's really a pleasure to be with you here this morning. Thank you so much for the invitation. I'm coming to you from Urbana, Illinois. It is really flat here. Okay, I love seeing the, the mentions of where everybody is from throughout Colorado and out west and Victoria. I love your background with the mountains. We do not have any of that here. That aside, we welcome any of you to our region, in our community anytime. We would love to have you visit at some point. So yes, I'm the acting regional dean of the regional campus of the U of I College of Medicine here at Urbana-Champaign. We're talking about post-COVID syndrome. The terminology is evolving. So specifically today, I'll focus on the post-acute COVID syndrome. I have no financial or other conflicts of interest. And this is what we'll talk about. We'll first start out with some resources and acknowledgements, talk a little bit about background data. We'll touch on the heart, patient advocacy, and then I'll have some concluding comments. So in terms of resources, here's one that's been especially valuable and helpful to me. This is the ACP Physician's Guide for COVID-19. It's available to the world. It's free. You just go to the ACP homepage. The URL is listed up there. You'll see it right on the homepage. You can click on that. If you do want CME or MOC credits, you do have to be a member of the ACP, but otherwise all the content is available to all. CDC also has some wonderful, is a wonderful source of information too. That URL is there as well. And then for clinicians, you may well be aware of this, but there's essentially a clinical hotline number, the CDC info, that 800 number there. There are people who will answer the phone and answer any clinical questions that someone may have. I have also found the SHEA website to be especially helpful, the Society for Healthcare Epidemiology of America. They have a wonderful collection of resources there. Every Sunday afternoon, 2 p.m. Central Time, you'll find me at their town hall. David Weber and other colleagues have been sharing their experience answering questions for the past forever, since the past number of months, since April, and it's been incredibly insightful and valuable, and I've been very grateful for their input. And some of the comments that I'll be sharing with you today come directly from some of the things I've heard at their town halls. In addition, the Infectious Disease Society of America also has wonderful information here at their COVID-19 Real-Time Learning Network. Again, it's open to everybody. You don't have to be a member to access this information. It's super helpful and very insightful. So we'll start out then with a little bit of background about COVID and everything that we've been dealing with. And I think humility is a good kind of theme for us as we think about this issue, the post-acute COVID syndrome and what we're dealing with. But, you know, the fact that we're still learning about COVID, the pandemic, all of this. And as we all know, what we think is true today may not be true tomorrow. So as we know with COVID, it presents with an impressively wide clinical spectrum. So everything from completely asymptomatic, and the understanding of that is still evolving, all the way through to critical illness with respiratory failure, septic shock, organ failure. And then with recovery, which is really our focus today, we are still learning really what encompasses that and what that's all about. We know that persons of all ages are at risk for infection and severe disease. We also know that fatal disease risk is greatest in those over the age of 65, those living in a nursing home or long-term care facilities, or those with underlying health conditions like obesity, hypertension, diabetes, and all of those. Then we also know that there's the multi-system inflammatory syndrome, which have been probably best described in children, but now there are increasing reports of this being described in adults as well. So again, there's a lot we're continuing to learn about the scope of presentation and the infection. This slide comes from Dr. Datta, who presented a talk on this topic at ID Week just a couple of weeks ago, the National Infectious Disease Meeting. And I thought this was a nice summary slide, but talking about COVID-19, and we have acute infection, which has been the focus of a lot of our attention and energy since the very beginning of the pandemic. Then we have the post-acute hyperinflammatory illness, there in the middle, and then more of the late sequelae, which is mostly what we'll be focusing on today. And the CDC is working in large part led by Dr. Datta to redefine the terminology that we're using to think about COVID-19 and these different stages of illness. So we'll come back to this a little bit later on. So when we think about the post-COVID syndrome, if you will, are the patients who have these persistent long-term symptoms. You might have heard the term long hauler. And this is a term that's been used, I think, in the lay press to varying degrees. And I don't know about you, but when I think of the term long hauler, this is what I think of: truck drivers and truck driving, perhaps out where many of you are, but out, you know, on the open road, the open highway, and driving these big semi trucks. So that being said, if you haven't seen this article or haven't read this article, this is worth reading. It's written by Ed Young. It was published in The Atlantic back in August. And as he uses the term here, long haulers are redefining COVID-19. Without understanding the lingering illness that some patients experience, we can't understand the pandemic. I think this is an important article. It's in essence, in large part, describing the patient's experience from the lay person's perspective. I personally found it insightful and informative, and it just helps. You know, it's like you have a coloring book, and this helps color in the colors to the coloring book, and it certainly helped me to better understand what patients are experiencing with patients who are in this situation, what they're experiencing. So there's been some more papers recently published. Here's a short opinion piece authored by Carlos Del Rio and colleagues that just appeared last month in JAMA about the long-term health consequences of COVID. This provides, I think, a nice overview of the situation and kind of our current understanding, current knowledge of what this is all about. And I'd refer you to this paper if you're looking for kind of a short summary as to what kind of what is going on and what our understanding of it is. So we'll move on to the data now. The data are somewhat limited, but I'll share with you some brief results of 5 studies that summarize kind of what's been found so far and what's been published in the literature as as far as these persistent symptoms are concerned. So this was an important study by Tenford and colleagues that was published in the MMWR back in July, talking about the symptom duration and risk factors for delayed return to usual health. And what was a really important feature of this study is the fact that it focused on outpatients. The other studies, for the most part, focus on not 100%, but for the most part, they all focus on former inpatients, but this was amongst outpatients. And this was a broad study in that it involved 14 US academic health centers across 13 states. They looked at adults from the time period of April through June of this year. And they did phone interviews, and these phone interviews were done a median of 16 days after the initial test date. So what they found were 292 respondents, 94% of them, or 274, reported experiencing at least one or more symptoms originally at the time of testing. And granted, these may well have been very minimal symptoms, but they did have some symptoms at that time. And what was found was that 35% of those 274 had not returned to their usual state of health by the date of this phone interview, which was 16 days since the original, since their test. And you can see down here, the older the patients were, the less likely they were to have returned to their usual state of health. So in terms of symptoms, persistent symptoms were things like cough, fatigue, and shortness of breath. But again, I think this is remarkable, this number of 35%. And these are outpatients. So these are people who are not seriously ill to begin with, but they have persistent symptoms even up to, more than 2 weeks after their original test. The persistence of symptoms correlated with the presence of comorbidities. So the greater number of underlying comorbidities, the more likely they were to have persistent symptoms. It was noted that age and comorbidities were independent predictors of continued symptoms. And then amongst these people who, were originally symptomatic, the median number of symptoms that they had were 7. And you can see here what their symptoms originally were: fatigue, cough, and headache. So, so this graph is helpful. The light blue shows or indicates the, those bars indicate the symptoms that were present on testing, and the dark blue shows the ones which were still unresolved by the test date. So you can see here, fatigue, cough, and headache were really common at the time of testing. And then for the ones that were unresolved by the interview date, again, still fatigue, cough, you see shortness of breath, congestion, confusion, and this is outpatients. I mean, it's, to me, I find that striking. The next study I'd like to share with you is one from Rome, and this was a post-care assessment of symptoms in patients who were hospitalized. So they were required to have 2 negative RT-PCR tests. This took place from April through May of this year. Excuse me. And they identified 143 patients. The mean age was 56. Excuse me, 37% were female. And then during hospitalization, you can see a large number of them had evidence of interstitial pneumonia. They were in the hospital for almost 2 weeks, the mean length of hospitalization there, you can see there. Some of them required non-invasive ventilation, and some of them were on the ventilator. So the mean time of assessment was 60 days from the day of their first symptom. So given that, 87% of them reported persistence of at least one COVID-related symptom, 55% of 3 or more symptoms, but none of them had any acute signs of illness like fever or anything else. The common symptoms which were persisting were things like fatigue, shortness of breath, joint pain, that a large number also had a worsened quality of life. So I think this is, if you're especially interested in this topic, this is certainly another study that's worth looking at and spending a little time with. This figure, I think, also shows this quite well. This is also from the same paper. So on the left, you can see the acute COVID symptoms all over there in the darker bars. On the right, the post-COVID follow-up, the persistent symptoms. So you can see there what those show too. So fatigue, dyspnea, joint pain were the most common things that we're seeing. The next study I'd like to share with you is one from the UK, and this is another one that's worth, again, if you're interested, especially interested in this topic, I'd urge you to take a look at this study as well. This study looked at the post-discharge symptoms and rehab needs in survivors of COVID-19. They were looked at, this is all examined after discharge. They found a purposive sample of 100 survivors. They were adults, and they were assessed on average 48 days after discharge, so between 4 and 8 weeks, and it was a telephone screening tool that was used. Some of these were in the ICU, some were on the wards. You can see there's kind of an interesting age difference between those in the ICU and those who are on the wards. Kind of the opposite, perhaps, of what I might have expected, but again, this is what they described. At any rate, new fatigue was the most common symptom. It was more common in the ICU group than the ward group. Breathlessness, same thing. You can see how many were experiencing this. Psychological distress, and then also a drop in this EQ-5D, which is kind of a quality of life measure. And you can see the things that they looked at here: mobility, personal care, and that. But again, much more commonly affected in the ICU group compared to the ward group. Here's a bar graph just depicting this. The orange shows the ICU patients, the blue, the ward patients, and you can see the persistence of symptoms. It's quite striking in both groups, but especially in the ICU, the patients who are hospitalized in the ICU. The next study is one from Paris. This one assessed post-discharge symptoms and quality of life. It's a single center study, and the data was obtained via a phone questionnaire. And looking at the study they're originally looking at were 279 patients who were hospitalized, again, March through April. They identified 120 patients out of this group, and they contacted them a mean of 110 days after admission. And you can see here the symptoms that persisted: fatigue, dyspnea, loss of memory, sleep disorders, concentration, loss of hair. In this study, unlike the prior one I just shared with you, there was no difference between the ICU and the ward patients. Then they also looked at people going back to work and also returning to sports activities. So again, this way, people were not back 100% in either of these activities either. So this is the last study I'll share with you. This is another one from France, and this is one looking at adults who had had non-critical COVID-19. And so this is the other study that had looked at both a combination of patients who were hospitalized and some who were not hospitalized. So they had contacted people by phone call and also did a review of their electronic health records at 30 days and then 60 days after they had tested positive. So again, it was a single hospital, University Hospital in Tours, France. They had identified 150 patients. This is March through June of 2020. And what they had found was at least 68% of this group had at least one persistent symptom. That was at day 30, 66% at day 60. And you can see here what they found: the loss of smell, loss of taste. So that was present. Dyspnea, and then asthenia was also present, or say fatigue. And then with persistent symptoms, it seemed like this was more commonly seen at day 30 in patients who had had severe COVID and also dyspnea at symptom onset. And then persistent symptoms at day 60 were correlated with the age of 40 to 60, hospital admission, and then also abnormal auscultation at symptom onset. So those are the studies. This slide shows the, put this down here. This slide shows the summary of the different studies and what was seen. And I think what's striking with all of these is that indeed these persistent symptoms and findings are real, and it's being described broadly, both in outpatients and certainly in inpatients. It also seems that those who are more severely ill at the time when they were acutely ill are the ones who are more likely to have persistent symptoms. Okay. Alrighty. All right, so here's another slide from Dr. Dada. So again, focusing on these late sequelae, which is what our focus is, we commonly see these cardiovascular, pulmonary, central nervous system manifestations of some sort. The underlying pathophysiology pathways are proposed, but they're unproven. We don't know. And the laboratory tests, really, in many ways, is completely uncharacterized. In some ways, it's all over the map. You know, some people may have persistent, as we all know, persistent PCR tests, antibody profiles. We just don't know. There's a lot of open questions about all of this. Okay. All right, this paper was published earlier this year by Greenhall and colleagues, published in the British Medical Journal. In case you're interested, that this published in August, it may provide some insights as well. One of the takeaways that I thought was especially important, we'll come back to this theme, but the concept of it's really important for us to honor the story of the patient. So rather than, you know, well, we can't assume that this is like, say, a common cold. You get the virus, you get the infection, you know, it's over and you're done. There's persistent symptoms here, and it's really important for us to listen to our patients and hear what they have to say. On the IDSA website, in here, there's the URL. They have a section on post-acute COVID-19 syndrome. There's some really wonderful resources there. Here's a few that I just want to show you, give you a breath of what's there. Some other things to listen to, but some podcasts, some videos, and things just focusing on some of these issues. The bottom one, this podcast, Survivors of COVID-19, are these physicians who were infected, including some of whom you may know or know of, Dr. Betty Creech, Anna Pearson, and Michael Sagg. Anyway, just really interesting insights to be aware of. Okay, so the heart is getting a lot of attention, understandably. I just want to spend a little bit of time upon this. This paper from JAMA Cardiology in July has gotten a lot of attention by Putnam and colleagues. This is provocative, and it perhaps raises more questions than it solves, but I think it's an important one. So it's from Frankfurt. They looked at 100 patients, and they looked at cardiac blood markers, cardiovascular magnetic resonance imaging. And you can see they also used age and sex matched control groups of healthy volunteers. 53% of these patients were men. The mean age was 49, and the median time from diagnosis to the CMR was 71 days. So some of the markers here were elevated, you can see. And of the cardiac magnetic resonance imaging, 78 of these 100 patients had essentially abnormal cardiac MRIs. But they had raised myocardial native T1, T2, which are markers of inflammation and suggestive of myocarditis. This late gadolinium enhancement was present in 32%, which is indicative perhaps of scarring and perhaps fibrosis, but anyway, that was present. Pericardial enhancement was present. In the patients who had severe findings here and very abnormal markers here, there were 4 patients. They underwent endomyocardial biopsy, and what they found was active lymphocytic infiltration. It's really, I mean, to me, this is quite striking. 71 days after their illness. So again, we don't have baseline information or like a baseline MRI and all this, but it raises a lot of questions about, well, you know, what is going on here. This study also got a lot of attention. You might have heard about this one, looking at athletes, and this was from Ohio State. Looked at 26 athletes, 57% of whom were male. They were all outpatients, and 12 of them had mild symptoms only. The others were completely asymptomatic. They were evaluated 11 to 53 days after their quarantine, okay? So their EKGs did not show any signs of ischemic changes. Their troponins, you see there, were negative. Their transthoracic echoes and the CMR showed normal ventricular volumes and normal function. but there were 4 of them that had signs of myocarditis on their magnetic resonance imaging with this elevated T2 signal and the late gadolinium enhancement. 2 of these patients had mild symptoms only, but it was also interesting that 8 of the 26 had this late gadolinium enhancement, but without the T2 changes, which suggests, again, prior myocardial injury. Now, what we don't have here, and again, it's provocative, we don't have baseline information on these patients, right? So before they got sick with COVID, we don't know what their baseline cardiac MRI showed. So again, raises questions, but there's a lot of concern about again, mild infection and what the impacts were in the heart. Now, this article just appeared within the last couple of weeks, published in JAMA Cardiology by Kim and colleagues on coronavirus disease and the athletic heart. This is worth a read for those of you especially interested in this topic. It provides algorithms, and I just wanted to show you a picture of one of the algorithms, but they provide an algorithm for management for high school athletes. This one is for recreational masters athletes. I don't know about you, but I would love to think that perhaps this is my category, but anyway, really not, but anyway, masters athletes. And then the third algorithm is one for competitive athletes, and you can see here what they're talking about. One of the main points in here, I'll just point out, this is rest and no exercise for 10 days rather than the original 14 days, which is what they had been, or that was what was recommended going back to May. So again, they do not emphasize the cardiac MRI up front. And I think for reasons that we don't know how to interpret it, it's expensive. And to be doing this on thousands and thousands and thousands of athletes, is that really what we should be doing right now? We don't know. There's an accompanying editorial in the same issue by Udelson and colleagues talking about this, and they do point that out. It looks like cardiac MRI will probably be the most sensitive test that can be done, but the question is how do we start? How and when do we start rolling that out, given the expense and et cetera, as far as trying to best interpret the findings that do come out of studies like that. So anyway, both of these articles I thought were quite helpful. I'd like to touch just briefly on patient advocacy, and then we'll wrap things up for my portion. The Body Politic is a support group for people who've been infected with COVID-19. What this group did is they created and analyzed a survey targeted at patients experiencing persistent symptoms. And they identified 640 people responded, and this is from April through May. Ed Young, in his Atlantic article, talks about the Body Politic group. And what they acknowledge, this is from, again, from their website, they say that they know that this study is biased and that it represents a biased sample of patients with higher recovery times than typically reported. But they're doing that to try to inform the public, health professionals, and inspire future research, and just give all of us a better understanding as to what's going on with people who are living with the after effects of COVID-19. So some of the survey results are here. Women were more commonly affected than men. But again, just as a caveat, the bias is that women are more likely to participate in body politic to begin with and subsequent in the survey. They also found that symptomatic and more severely ill patients were more likely to develop prolonged symptoms. Even those not hospitalized may experience prolonged symptoms, and we saw that in the very first study that I shared with you today. And then there were a number of symptoms that were suggested of this, what's termed dysautonomia, so a perturbation of the autonomic nervous system. So things like orthostatic hypotension, the heart rate, those kinds of things. And it's not clear what's going on with this. If that's indeed, what's happening, and if so, why? And, it's hypothesized that perhaps this arises from damage from the virus or an overactive immune system. We don't know. But then a number of patients describe this post-exertional malaise. like walking up a flight of stairs and then being confined to bed for 2 days. I mean, really significant changes. It's been likened to myalgic encephalomyelitis, or what we know as chronic fatigue syndrome. And we just don't know, and we just don't understand this well. Patients have said managing their fatigue becomes like a full-time job. There's some patient quotes from Body Politic, which I think are illustrative, and there's a couple of them here. I'll just read the first one for you here for a moment. But this person says they feel terrible for a week, then have 2 good days, then back to feeling terrible. And when I say 2 good days, that just means I can walk to the kitchen without feeling like I need a break in between. I feel as if I have more of a disability now than just some virus bug. Okay, so what have some institutions been doing? Some of the larger cities out east, especially in New York City, New Jersey area, they've established these post-COVID clinics, if you will, or like COVID Recovery and Rehabilitation Center for Post-COVID Care. And what they, I think what health professionals have realized is that these patients require care from multiple specialists, so like pulmonologists, cardiologists, neurologists. Yeah, you see there kind of the whole gamut of specialties. But infectious disease physicians, interestingly enough, may not necessarily need to be a core piece of these groups, in that it's, you know, this does not represent, well, we don't think anyway. Who knows? We'll see. This is what many are thinking, or what a number of people are thinking currently. However, is that infectious disease is not necessarily the primary subgroup, if you will, that, or subspecialty that may be required in such clinics. But you'll see it's these have been established in places like New York, Chicago, Los Angeles, and other health systems. They've really become a medical home for patients who have developed these symptoms. From the ACP's COVID-19 site, this is a short video, a screenshot of a short video from the group at UCLA that set up a one of these clinics, and you can see they talk about how useful it is to have a pulse oximeter or a blood pressure cuff at home, the usefulness of doing orthostatic vital signs, and what they describe as patients just are not the same. They're not the same as what they were at the time of admission. They've changed. There's neurologic and psychiatric changes, residual pulmonary symptoms. It's just not clear what's going on or why, but these are the kinds of things they're noticing. So what about screening? Should we be screening for this? And there's growing data. I think it's fair to say there's growing data, but there's really not robust data on this yet, but hopefully there'll be more of that soon. I do think it's important that athletes are screened, or those doing strenuous exercise. And you want to screen these people with an exam, a cardiac evaluation, a forced rest period, which now is recommended for 10 days, and then reevaluate. You want to watch for evolving data. I think one of the concerns with, well, whether it's athletes or just the heart in general, is given the large number of infections we're seeing in the US and all over the world, the concern is if there are real cardiac issues, persistent cardiac issues, developing, or that could occur, that means a large number of people will be impacted. So at any rate, at this point, yes, let's look at athletes. Maybe worthwhile to do anxiety or depression screens, especially in older persons and perhaps those who are hospitalized in the ICU. There may be more subtle deficiencies in concentration. This is something also that needs to be studied. And again, to set up a clinic, we want to think about the goals for doing that. And it's really important to continue to do research in this setting, just to try to better understand this as best we can. And I think, bottom line, patients really want someone to listen to them and for them to be validated. In terms of the pathogenesis hypotheses, here's a few thoughts for these late sequelae. One is, is this all due to organ damage from acute infection? Perhaps. Could these be manifestations of long-term hyperinflammatory states? Maybe. Could there be a persistent virus in a protected reservoir, similar to what we've seen with Ebola? Perhaps. Is this all part of a post-ICU syndrome? Maybe, which is slow resolution of symptoms, things like PTSD and memory and concentration problems. Perhaps. Could this be a combination of all these things in varying degrees? Yeah, there's just a lot we don't know. Here's a number of open questions. I think these are really important questions here. One of the ones that I find these a little provocative. One that I find especially provocative is this one. How should recovery be defined? What are we talking about here? I'm not sure we really know yet. So I just have a few concluding comments. Again, I think it's incredibly important for us to listen to our patients. The patients will tell us what is wrong. Dr. Fauci gave a grand rounds in the Harvard system on September 10th. This is available online if anyone wants to watch that. But these were some of the comments he shared. One was, do not ever underestimate the potential of pandemic. We always must do ethically sound research even during the outbreak. It's critical. We have to be flexible and humble enough to change guidelines and policies as the data evolves. And then lastly, we have to make a commitment to address the social determinants of health, which have been really shockingly exposed during the pandemic. So in conclusion, the persistence of symptoms is common after symptomatic COVID-19. And we see it more commonly in those who are hospitalized, severely ill, older, those with comorbidities. Most common persistent symptoms appear to be fatigue, dyspnea, and cough, and long-term fevers are distinctly uncommon. There's a pressing need, for the reasons we talked about, for ongoing investigation of the long-term cardiovascular consequences of COVID-19. It's important to screen high-performance athletes. And then healthcare systems should consider developing multi-specialty clinics to provide post-COVID-19 care. And then lastly, high quality research is necessary, it's essential, and especially in a pandemic. A pandemic is not an excuse not to do high quality research. So that's all I have, and I'm happy to turn it over to Carolyn. Thank you.
Thank you so much. Thank you, Dr. Jokela, for that comprehensive and thought-provoking presentation. I know there are likely many questions. I have about 10 written down myself, but we encourage you to enter them into the chat. We are very fortunate to have Donna McGregor here with us today. She's an instructor in medicine and infectious disease at the University of Colorado School of Medicine, and she's going to present a case for us. And again, please start entering those questions in the chat. Donna?
Hi there, thank you. I have a lot of stuff that, same slides as Dr. Jokela, so they'll be familiar to us. And I have a case that really demonstrates a lot of what she just said. So I think that'll be kind of interesting. I do want to comment too that UCH just started a post-COVID clinic. So if anyone would like to refer, it's Dr. Sarah Jolly, Jolley, and she's a ICU specialist and saw a lot of these, continuing problems. So she just started this clinic. So I'm going to share my screen here. All right, and let's see if I can get this onto. Slideshow. Okay, so I have some poll questions, so I'll go through those quickly. This was actually a patient of mine. This is a 33-year-old male with history of obesity and hypertension. He's evaluated in the ED and is diagnosed with COVID-19. He's febrile, anxious, dyspneic. His D-dimer is 7,290. The CTPE was negative for PE and his O2 set was 94%. So the ED staff decided to discharge him with instructions to quarantine and to follow up with his PCP. So as his PCP, would you start him on broad spectrum antibiotics, start him on VTE prophylaxis, repeat the CTPE, get an echo, or insist on hospitalization for more thorough evaluation and monitoring. So I'll give you a couple seconds. And then we'll go on to the next one. Okay. Oh, and here's our poll. Couple people would start them on VTE prophylaxis, get an echo 30%, and like I thought, he should have been hospitalized for a more thorough evaluation and monitoring. When we get down to the guidelines at the end, we can have more of a thorough answer on this, because it's hard to say what exactly the right response is. All right, so next one. There we go, question 2.
And if Donna, if you want to advance your slides too.
It doesn't seem to be advancing. I think it's because the poll is on my thing here. So I'll just read the poll, and then I'll see if I can advance when we're done with the poll questions. What proportion of COVID-19 patients with COVID pneumonia have persistent dyspnea after hospital discharge? And actually, we just saw those slides from Dr. Jokela. I don't know if anybody paid attention to dyspnea, but less than 2%, 5%, 15%, 30%, or 50%. So I'll let people answer that one. Okay, and 60% of people said 30%, which is the correct answer. The correct answer for outpatients, as we saw from her presentation, patients who were in the ICU tended to have a higher percentage, 40%, 50% with dyspnea post-discharge. All right, and the next. Okay, and the third polling question is secondary infection is common after viral infection. You suspect that your patient who was diagnosed with COVID-19 2 weeks ago and then seemed to improve, but now presents to your office with recurrent fever and productive cough, may have a secondary infection. What's the most common secondary infection noted after COVID-19 diagnosis? Acinetobacter, Candida, Aspergillus, Strep pneumo, or Klebsiella? I'll give you a few seconds to answer that one. Okay, very good. That is correct. Strep pneumo is most common bacterial infection, secondary infection seen after COVID. Acinetobacter, actually, there was a study in Iran, and that was the most common there. There have been some Candida and some Aspergillus, and they think that that is because of the steroids given to some of the ICU patients. So let me see if I can advance this. Okay. All right. So here's my case, which is the same patient. He went to the ED. He was diagnosed in 3/24/20 with COVID, was sent home to quarantine. Then he had progressive dyspnea, anxiety, inability to tolerate PO. He was hospitalized 3/27 to 3/29. Chest x-ray showed a multifocal pneumonia, but he had normal O2 sats. They didn't give him any antibiotics. He was treated with Zofran, Ativan, and at that time his D-dimer was 940. Then sent home, and then he returned to the ED on 4/9 with recurrent fever, dry cough, and shortness of breath. He had an abnormal ECG, negative troponin. This time his D-dimer was 7,000 290. The CT was negative for PE. His O2 sets were still stable at 94, and chest x-ray showed slightly improved multifocal pneumonia, and they said to follow up with ID, which was me. So here are, this is not his x-ray or his CT, but these are common presentations with COVID-19, multiple bilateral peripheral opacities in the chest x-ray, which is what he had. And then the CT, the ground glass opacification and fibrosis. So down here, his underneath the figure was his actual results on his CT. No embolism, but he had ground glass opacities, most prominent in the right lower lobe, multifocal pneumonia. So case questions, questions I had, how long do respiratory symptoms persist after diagnosis of COVID-19? And we know from what Dr. Jokela just showed us, well, we know at least a couple weeks to a couple months, and about 30% of mild to moderate cases can have persistent dyspnea. What are the recommendations for ID follow-up of COVID pneumonia? What are the recommendations for ID follow-up or anybody's follow-up of elevated D-dimer? And could this patient have a secondary infection? So here's the same graph that she showed us. So if we look at dyspnea, it was roughly 30% or so, and then cough, which he also had, was about 50%. And he had other symptoms as well, specifically anxiety and depression, which were increasing. So here's some reports, the same report that she shared with us about from the United Kingdom that showed 72% of ICU patients and 60% of ward patients experienced fatigue and breathlessness 4 to 8 weeks post-discharge. And then another study looking at MERS survivors and found that 36% of them had some dyspnea at 6 weeks post-discharge and had residual chest x-ray changes, which most of them were due to pulmonary fibrosis. And a couple other studies of lung damage after COVID. USC team looked at CT images of 919 patients. They found that the lower lobes were most frequently damaged. There were scans were riddled with patches of inflammation, and that visible damage normally reduced about after 2 weeks. And there's an Austrian study that also found that lung damage did lessen with time. 88% still had visible damage at 6 weeks, but by 12 weeks, this had dropped to 56%. But that's, 56% at 3 months post-discharge. And here's some pictures of some scans that came from Austria. The red shows COVID-19 damage. So that was the onset of COVID. And then 6 weeks after COVID, it's getting a little bit better, but again, the red is COVID damage that's still there. And here's 12 weeks after discharge. And another article, which was very good to look at about long haulers, was from Marshall and was in Nature there. That's another good one to read. And it was a nice short summary at symptoms that these long haulers are experiencing. So VTE, unlike MERS and SARS, acute COVID infection is associated with a high prevalence of VTE disease. They did a large meta-analysis of 1765 patients, and they saw the overall incidence of VTE, which is primarily PE, but also some DVT, was 21.9%. And they found a number of those patients were actually diagnosed during their recovery period, their COVID pneumonia recovery period. So, we need to keep that in mind as we're following up these patients over the weeks and months after their diagnosis. And here was a big study on D-dimer elevation, prevalence and outcomes. So my patient over 7,000, you know, really kind of worried me for a 33-year-old. This looked at 2377 adults hospitalized with COVID in a large hospital system in New York. 76% had elevated D-dimers at presentation. And they found that those people with elevated D-dimers at baseline were more likely to have critical illness, which makes sense. The adjusted odds ratio was 2.4 there. Any thrombotic event, which certainly makes sense, was 1.9 odds ratio, but also acute kidney injury, 2.4 odds ratio, and death, 2.1. And their conclusion was the optimal management of patients with elevated D-dimer in COVID requires further study. So that didn't give me much guidance on that one. This graph is from their report, and it does show that, you know, elevated D-dimer, there is more mortality that you see in the left. And then on the right side, they split it out to what the D-dimer actually was. And my patient was in this over 2,000. He was well over 2,000, but his risk of mortality was significantly higher than someone who would have had a normal D-dimer. So secondary infection, this was, there haven't been too many studies on that yet. It's just kind of coming out, but this was one of the largest studies of 257 patients with COVID-19 from China, enrolled in January to February. And they found that 94% of them were co-infected with one or more pathogens. You look at the graph on the right here and see the many pathogens that they had. Strep pneumoniae was the most common, followed by Klebsiella and then H. flu. So when you're looking for follow-up recommendations, as Dr. Jokula said, this is, you know, in transition, it changes all the time. There's really not a lot of follow-up. We have, you know, our US NIH COVID guidelines, which are helpful, but not very specific. And then this was a more specific recommendations from the UK. And it's for the general practitioner of what they recommended for follow-up of mild to moderate COVID pneumonia. So, which my patient was classified as that. So they're recommending at 12 weeks post-discharge, do a chest x-ray and take a look at that. If they had a PE, you're gonna do some post-PE follow-up, which basically means repeating their CT and for pulmonary embolism. If the chest x-ray is abnormal, they recommended ordering a full set of PFTs, which is interesting. I haven't done that yet, but I'm considering that. If they're fine, you could discharge them from follow-up. If not, and they have abnormality on their PFT, you're gonna do a high resolution CT, consider an echo. If they have evidence of pulmonary PVD as pulmonary vascular disease, considers, you know, referral to specialists there, or interstitial lung disease, you want to refer to an interstitial lung disease specialist. Other than that, if they're quote normal, then you discharge them from follow-up. If we look at our guidelines.
I'm sorry, I just want to let you know, we just have 2 minutes left.
Okay, I have like 2 slides left.
Okay.
Very quickly. So our guidelines, basically, I'll skip down to the bottom there. They say insufficient data to recommend for routine prophylaxis for patients without signs or symptoms of VTE, regardless of the status of their coag markers. Then they go on to say, though it's not recommended, there have been a couple studies where they did use 2 regimens, rivaroxaban and betrixaban. So I'll let you guys look at that if you need that. And then they have inclusion criteria here Basically, they treated people who were older, had D-dimer levels that were over 2 times their upper limit of normal, which certainly is my patient, or had a previous PE or DVT or cancer. So last slide, my summary. A lot of people have post-discharge symptoms. Some of them, as far as pulmonary, may require pulmonary rehabilitation. A lot of them have elevated D-dimer at baseline, and they are at increased risk for AKI, thrombotic events, death. Case series have shown an overall incidence of 22% of VTE for these patients, although prophylaxis is not recommended, but it may be considered for high-risk patients. And then secondary infections need to be considered: strep pneumo, Klebsiella, H flu, and others post-COVID infections. So as far as my patient, I will stop sharing my screen here. Okay, I think it's off. Okay. As far as my patient, he is overall feeling better. His D-dimer is trending down. Last time we checked, it was like in the 900s. And he is having significantly increased anxiety, depression, and PTSD though. So another post-COVID issue that we need to watch for. Anyway, I'm finished. Thank you for your attention, and hopefully right on time.
So we've gone a bit over, and I know we don't have much time for questions. I don't know if Dr. Jokel and Donna can stay on. I wanted to just check with you all. You can. Okay, terrific. Donna, you can. Okay.
Minutes, yeah.
So we wanted to offer that if anyone has any questions, to go ahead and start entering them. I saw a few in here. Sarah, I'm going to offer to have you unmute and ask one or two of your questions.
Sure, I had so many, so I don't, if anybody else has any, feel free to jump in. I was thinking of a patient of mine who had prolonged dyspnea, mild hypertension pre-COVID. He's foreign born and traveler, and he was in March. And so as he called me and told me about his chest pain that went on and on, I just told him, well, you're better, hang in there, you're better. And so I'm sort of wondering about, what sort of screening I should be doing for him. He's fine now. I mean, after about 6 weeks, he was better and he's fine. He has no symptoms now. My other thought was about the public health messaging. Dyspnea is a horrible feeling, and do young people know that this is actually common? I sort of wonder how we should be changing our public health messaging about the risks for young people. And of course, the elderly having prolonged symptoms. And those were my two questions that came to mind first.
I'll hop in here. Sarah, thank you so much. I think those are really important questions, and thanks for raising them. First, with the public health messaging, I tell you, that's one of the things for me, kind of more personally, it's front and center in terms of, what needs to be done and how we do this. There's an art to that, and there are many, many people out there who know how to do this well and appropriately and effectively and all of that. I think it's critical. I think the temptation is to focus solely on deaths, like the death rate in young people versus, older people and all of that. Because of these prolonged symptoms and findings, and especially with the underlying cardiac things, which we're really just starting to scratch the surface on, I think it's huge that the implications of this are actually really significant in terms of numbers. So I don't have an easy answer for you, but I think that aspect of it is important to be part of the messaging. Like this is not, in a bullet, kind of elevator speech message. This is not the flu. This is not the common cold. There's a lot more to this that we don't yet understand, and we're just beginning to understand. So thank you so much for raising that point. And I think whatever we can do to help get the message out about there's so much more to this that we still don't know a lot about is really critical. Your other question about the prolonged chest pain and all that, and about whether or not to get an echo, I think is a really good question. I'll be interested in knowing what others on the call think. I mean, in essence, there's not necessarily good substantive guidance on that just yet. But I think as clinicians, if we're concerned, more on at this point, one-on-one level, yes, we get the echo. But, kind of more globally, are we then recommending echoes for everybody in this situation? I don't think we know yet for sure. And that's the challenge. So again, it's a rapidly, it continues to be a rapidly evolving pandemic. The data continues to rapidly evolve. I mean, just this morning, like 10 minutes before I hopped on the call with all of you, there's another study that came across, in my inbox about, cardiac complications related to COVID. There's so much we're learning kind of all the time. I think it's going to continue to evolve, and we'll just have to, be alert and keep our ear to the ground as best we can with all the new information coming out.
Thank you.
Along those lines, is there any early information about cardiac complications that they're seeing rather than just the MRI findings, but real aberrancies and rhythms?
Yeah, Karen, that's a really good question too. I haven't seen any studies on that. I have seen a few reports of, or kind of just passing comments, if you will, like, the athletes cannot return to exercise, if you will, until after their arrhythmias. And what that means, I don't know, like, occasional PVCs or something, I don't know, until after those resolve. And I'm thinking, well, wait a minute, how many are there? How often does this happen? I don't think we know, or I don't know. Maybe, again, some of you on the call may be aware of some other studies, but I think there's just a real need to collate this information and collect this information so we can study it and better understand it in a more rigorous way. So it's a really good question. I don't have a good answer for you.
Have you heard any, Donna and Dr. Jokela, have you heard any early successes with the way we manage dysautonomia in other, in other settings with, POTS and other kind of things that seem to be similar in presentation?
I have not. I haven't actually seen much management on that topic at all, or much in the literature at all. I don't know. Maybe Dr. Jokela has seen more.
Yeah, Donna, I'm with you. I haven't either. I think it's really interesting about this dysautonomia concept that's bubbled up here. In some ways, I think it's giving more credence, if you will, to this phenomena, not only with chronic fatigue syndrome, but others. Like perhaps it's just, again, expanding our understanding and appreciation for the possibility of this. I think it'd be really exciting if we could be able to drill down and better understand the pathophysiology behind it. And yeah, just to better understand what's going on. But I'm not aware of any specific studies around it, not yet. Hope that with some of these post-COVID clinics at some of the big centers where there are a lot of patients, that they may be able to collect some of this data and better understand what's going on.
So I want to thank both of our speakers. I think between you two, you presented such a nice range of what we're dealing with. We're dealing not only with the acute illness, we're dealing with complications that can present a couple weeks or to months afterwards related to their hypercoagulability and other issues, secondary infections, and then all the way to these conditions that we think are non-infectious that we really are characterizing in this post-COVID syndrome. And so I think it's really a huge spectrum, and it's very challenging to all of us providing healthcare to these patients. And I want to thank you both for such a comprehensive and thought-provoking presentations. Thank you. Thank you.
Yeah, thank you. So nice to be with you this morning. Thank you, Donna. Enjoyed your presentation.
And yours as well. Thank you.
All right. Any closing words, Victoria?
Yes. So again, I put in the evaluation in the chat and our website where we're going to have all the resources, the uploading of this session. And I really wanted to make an important announcement that we will have a session next week, not in 2 weeks because of the fall holiday. So next week we will have our next session on the 17th opposed to the 24th, I think it is. Yeah, so opposed to the 24th. So we'll see you next week on some employee infection prevention and health issues. And if you have any questions, you are always welcome to email me or chat me, and also with Caroline as well. We are here to answer any questions. But thank you all for staying and staying over time. We appreciate it. We appreciate our speakers today. So thank you all. Have a great rest of your day.